Well, thank you for that very nice introduction. You know, Arup gives this course in America, and I've been honored to be in that, so it's even nicer to be here in India doing this. So, what is the worst fear that you have when you do a multifocal patient? And by the way, I have no financial interest here. And your worst fear is that you did perfect surgery, and they're 20/20, and they're still unhappy. That is so depressing. And you've heard a lot about the cornea, David. You're going to hear about the macula. Think about how OCT allows us now 10 micron resolution to get all this information about the macula. But yet we go into this knowing so little about the cornea. And that was the theme on some of the previous talks. So I'm going to talk to you about the eye trace. Now this is a topographer. But we're actually able to do at the same time with the same machine wavefront aberrometry. We get the wavefront, the higher order aberrations. But that alone doesn't help you very much unless you can separate the aberrations, higher order aberrations coming from the internal optics, which would be the lens, and the external optics, which is the cornea. And this machine plus the NIDEC OPD are the two that can do that. So let's just start with a case, an unhappy restore patient. Now this person's 70. They had a restore 2 years ago, and the left eye's a cataract. Now look at that first eye. It's 20/20 uncorrected. There is some cylinder, and he's got an anisometropia, 2100 in the left eye. But there's something wrong with this picture. He had his first surgery 2 years ago. Now, how many times when you get 20/20 and they have this large aniso do they wait so long? That's his chief complaint. He's bothered by the imbalance. So let's look at this eye. He has basically a wraparound tear in the posterior capsule. I don't think I have a mouse. Here's my mouse. Right over here is the tear in the posterior capsule. And over here it looks to me like the haptic is in the sulcus. So we got one in, one out. And the posterior capsule is all open right over here. So the question is, what would you do? So how many people would do the other eye with a multifocal? Just raise your hands. Remember now, we'll go back here. How many people would suggest do it in his other eye? How many people would treat that as stigmatism? He's 20/20 uncorrected, but he's got a diopter of stigmatism. Would anyone treat that with LASIK? Okay. How many people would take the lens out? Nobody's got an open capsule. He's 20/20. No one would take the lens out? Not all right. So this is the challenge, right? He's got an open capsule. So let's do the aberrations. Now this is simulating what it would be like with glasses. In other words, higher order aberrations or the fourth order aberrations. So this is the left eye. It's phakic. It's got a cataract. And this is like a point spread function. This is his right eye, the multifocal eye, as though he had the diopter of cylinder. And what do you see? The point spread function in terms of that E is blurrier. So what he's telling you is actually true. He has got worse quality vision from the multifocal eye. So let's look at this. This is his eye, and this is the total aberrations. And I tell the patients when I show them, you don't want to see a lot of bars. It's like static if you were judging sound quality. You don't want to see aberrations. And this is showing what's coming from inside the eye, and this is showing what's coming from outside, such as the cornea. And you see the topography looks normal. So where are his aberrations coming from? Where is the quality of vision being affected? It's from the internal optics. It's the IOL. Now you're probably going to say, well, I know multifocals, there's a compromise in the optical quality. Don't they all show that? So here is another patient, different patient with the restore, and you see there's no aberrations from the internal optics or the entire eye. Again, a normal quality of the cornea. So this is this patient now, and so the question is, what would you do? So now I've shown you that his complaint is real. His optical quality is poor. He's got poor optics. So how many people now would exchange this lens? He's got an open capsule. He's 20/20. Posterior capsule tear. How many people would exchange it? Okay, a few now would exchange it because how many people would just leave it alone and do a multifocal in the other eye? Few, okay. How many people would do his other eye to treat the imbalance with a monofocal? Anybody would do that? Okay. So that is what I in fact did. His main problem was imbalance. So he said, how important is it to read without glasses? Yeah, I just want to be able to see. My eyes are they're not working together. So I did his left eye, and I did it with a toric IOL. And he came out 2020, Plano, and I said, the benefit of this is because, the first thing you have to do is explain that his lens, one is in, one is out. Maybe it's tilted. Maybe he's getting aberrations from the multifocal. So I said the benefit of this is when I do your other eye, the imbalance will go away, and maybe when you're out at night, the good eye will help you to sort of tolerate the aberrations you're getting. So I did that, and I said, okay, so now let's give it, remember, he's 2 years post-multifocal. Let's give it 3 months.
We have seats in the front. Why don't you come over and join us in the
let's give it 3 months and see if you can get used to those aberrations in your first eye. And he called back in a couple days after the surgery, just a few days after surgery, says, I made up my mind. I don't want to have all of that the rest of my life. I know it's risky. I want you to try to take the multifocal out. So we went ahead and exchanged that. I won't show the video of that. We don't have time. But this is his vision now with the monofocal in that first eye. He was actually able to avoid vitreous loss, put in a monofocal in the sulcus, and we in fact got 2020. Now, yeah, I know, they started the timer wrong. So this is his pre-op. Remember now, this is like point spread function. The blur there is assuming he was wearing glasses, and this is with a monofocal lens. So you can see the difference. The only difference between these two photos is we've got the monofocal lens in there. So his optical, now here's his wavefront. Remember, the upper is the total eye. This is the internal optics. This is the external optics. And now look. So he still has a little bit here, but dramatically reduced, and he was extremely happy. So, case number 2, 55-year-old chiropractor, second opinion, maybe fourth opinion, 18 months after we resume with a phenomenally good result. Look at this, 20/20 J2 with no glasses at all. He is dead on Plano. But his problem is ghosting and halos. And he says, I know they told me to be patient, I would get better, I have been, but honestly, after 18 months, I don't think it's any bit better. And so he found on the internet, this sort of thing where you can show your doctor the problem with your vision. And he circled this photo off of this internet tool. This is what I'm seeing. Well, let's look at his wavefront. So this is the total eye. He doesn't have much in the way of cylinder. That's the far right. And you see here he's got some aberrations from the cornea. And where that's coming from is right here. The steepness changes, and whenever you see the topography change right in the middle, that induces something called coma, which is very, very difficult to tolerate with a multifocal. So this is, again, is the aberrations. You see on the far right-hand side, that's the resume. He's 20/20 Plano, but look at the quality of vision. It's poor. And then this is his right eye, which is phakic. So what do you do? 20/20 Plano, resume, 18 months, lens in the bag. How many people would take it out? Put in a monofocal. How many people would say 18 months isn't enough? You probably need another 18 months. And no? Okay. Well, needless to say, I took it out. Here it is pre-op. Okay, you see the aberrations from the cornea, the coma. Now, what do you think it's going to look like post-op? There's the monofocal. The aberrations are exactly the same, right? Why? Because they're from the cornea. But he came in the next day and said, I know it's a little blurry. I just had surgery yesterday. I can tell you already that this is much better. So in other words, he had this coma from his cornea. He also had a large pupil, and that's the key. It's the combination of corneal aberrations and the larger pupil that creates the aberrations, the loss of contrast. And when you add the loss of contrast from the IOL, it became too much. If he had a very small pupil, because he was not as young, he was 55, you might be able to get away with that. Here's case number 3. 10 years post-LASIK. Oh, I'm sorry. Yeah, 10 years post-LASIK, but 4 months post-restore in one eye. So she's 57, she's young, hates glasses, had LASIK for that reason, absolutely want the restore, and it's not clear. Now, she is, okay, well that makes sense. The left eye, which is the LASIK, the restore eye, is 2100 uncorrected because she still has residual cylinder. She's 20/20 minus. So, everything else is normal. 4 months, her doctor says, you just need to have LASIK enhancement, right? So, why is she coming to see me? How many people would do a LASIK enhancement for someone who's unhappy, but it's 20/20 corrected with the cylinder? Yeah. Makes sense, right? But she said, the vision is so bad, I'm just not so sure I did the right thing. So what are the things you can do? You can try contact lens, you can try glasses. And we did that, and she said it's definitely better, but it's still not that clear. Uh-oh. So this is her, and she has a nicely centered restore. This is actually a tear in the anterior capsule, but the lens is centered. So should we take it out? Well, we went ahead and we did wavefront. And look at this now. The restore eye, again, this is high order aberration, so what the machine is doing is it's simulating. You've already corrected the sphere and cylinder, and then what's the quality of the vision like? And the quality is not so good. Why? Well, let's look at her topography. This is the post-LASIK eye, still without cataract surgery. No cataract. There's the cornea. And this is the cornea in the eye that's had the restore. And if you look at the lower left, the higher order aberrations from the cornea are quite high. She's got a large pupil, being 57. And so, to me, this looks like another case of aberrations in the cornea contributing to the total eye. So, I went ahead, I took the lens out. This is her aberrations from the cornea with the restore. What do you think it's going to look like when I took the multifocal out? They're still there. There's with the monofocal. And you see in the lower left, you have a lot of aberrations from the cornea. But this is a comparison. And on the top, this is with the restore. This is the total aberrations. And the bottom, this is with a monofocal. So she still has aberrations from her cornea, but you can see they're less. Well, she came in a week later and said, amazing, I can tell, it's 4 months now, I can tell it's dramatically better. I can't read it all up close, but I'm so happy because it's clearer. And she wrote up a wonderful review on Yelp about our practice. So you can see that she still has aberrations, but how it is less without the multifocal. And this is a comparison, her aberrations with the multifocal, with the monofocal, with that post-LASIK cornea. One more case to make the point. Unhappy refractive lens exchange. Now, she's a hyperope. She got a restore in the first eye. This was in Los Angeles. She's 2 months out. She got a restore. Look, she's 20/20, 5J8. Refraction's pretty good. She has halos, but her number one complaint is anisometropia. She's a refractive lens exchange, contact lens intolerant. One eye's minus 25, the other's plus 3.5. I said, why didn't you just get the other eye done? She says, if I got my other eye done and I end up seeing like this, I'm going to have to retire because I can't work with the vision in my right eye as a refractive lens. How many times does someone who's plus 350, contact lens intolerant, unhappy to end up minus 25? How often does that happen? Does anyone want to see the wavefront? Raise your hand if you do. Okay. Well, there it is. That's her wavefront. Remember earlier I showed you a restore patient with a normal wavefront? It was actually this patient. That's totally normal. So the optics of her system are fine. And this is the eye that, it's not cataract, it's a phakic. So I kind of had to go back to the drawing board, and I said, I did a 4-prism base out test, and she's a monofixator. She is actually a left monofixator, a tiny, tiny little bit of movement. And I asked her, did you ever have a patch or anything? Yeah, my right eye was, the left eye was patched when I was younger. So she has a little bit of amblyopia. And no wonder when she's forced to use the amblyopic eye, she's not happy with the vision. I said, look, no harm done, but your better eye, just put a monofocal in, and then you won't have that anisotropia. So, I've shown you 3 cases where the patient was bothered by quality of vision, and yet they were 20/20. And the surgeon didn't know what to do because the exam was normal, and they told the patient, relax, everything's normal, you'll be fine. And so the doctor is thinking, this patient is really fussy. I got a really fussy patient, and what do we offer them? Neuroadaptation, get the laser for your astigmatism, let's do a YAG capsulotomy. Okay? So, in actual fact, they either had optical problems from the tilted multifocal, from the corneal aberrations. And so what I do now is I do all of this on anyone who is a candidate for multifocal. Certainly if they had prior LASIK or RK. I'm very reluctant to put in a lens if there's a torn rexus or weak zonules of multifocal because of the influence of tilt. And I don't usually put one in the sulcus, or I have to think twice if there's a large zonule dialysis. Multifocal diffractive lenses are a very unforgiving problem if you have anything else wrong. So this is some pre-op patients. This patient is +5, would love a multifocal. But when I look here, hardly any cylinder. There's the topography. There's the aberrations from the cornea. And this is that coma case. A lot of coma from that topography elevation splitting the pupil. Same in the other eye. So we said no multifocal, monofocal. Here's a patient would love to have a multifocal. A little bit of cylinder in the right eye. We do the aberrations. Look at the cornea here. Too many aberrations. So no multifocal. We're going toric, mini monovision. Okay? And then this, just one last one here. Let me erase it. Would you put a multifocal in this patient? Look at the corneal aberrations here. Risky. There's the other eye. Risky. And one final one. This is a patient who had bilateral Tecnis multifocals, 20/20, but couldn't tolerate the vision in the left eye. Why? Because the capsule was torn, they put a 3-piece Tecnis multifocal in the sulcus. So even though they're 20/20, look at the effect of decentration there on your far right. Okay? So there's aberrations from a decentered lens. Right? So the bottom line is, too often now, we don't know enough about the optics of the eye, and we're finally getting some instruments that help us out with this. Thank you.